Hello, everybody. Welcome to Cycle 2, Episode 1 of the Ibarra Exchange. I'm Luigi Pesce from New York, and we have psychologist and expert in obsessive-compulsive disorder treatment and telemedicine, Alejandro. How are you, Ale? How's the fall in Sevilla, Spain?
Thank you, Luigi. Everything is okay. Thank you for having me here in the second episode of Ibarra Exchange.
Absolutely. Cycle 2, Episode 1. We have a very special week today. Today is October 11, and it marks the beginning of the International Awareness Week that lasts until October 17, International Awareness Week of OCD. What can we expect this week? Do you have any conference prepared? Any Facebook Live?
Yes, absolutely. We have some online event tomorrow at 7 o'clock here in Spain at 1 o'clock p.m. Eastern Time, Boston, Miami, New York. We have the Facebook Live. Then continue my session with our clients in our practice office. And next Friday is the next video with affect with suffer in process advance of recovery. So we have some online events. Stay tuned by YouTube and Facebook.
Absolutely. Both the Ibarra Exchange and your personal website. Very, very excited. Hopefully everything goes well in this International Awareness Week. And I'm happy that people can still do it via Zoom. And it wasn't a barrier. Some neuroscience conferences here in the United States were canceled because of the pandemic. But let's get into subject. Let's get into business. When I started studying psychology, they always give you the 5 types of theory or framework. One of them was the Freud psychodynamic. Okay, so debating in psychology is something that always happens, whether it's the treatment or whether it's the basis of a particular disorder. You always have the biological basis versus the cognitive behavioral, the psychodynamic. Psychodynamic is not just anymore that much, but there's people that do it. When it comes to OCD, there's a small minority of professors and doctors and psychologists that believe that the cognitive treatment, only cognitive treatment, is the way to treat this disorder, even though there is a cognitive behavioral disorder, obsessive cognitive compulsive behavior. You disagree completely with them. You believe in cognitive behavioral treatment, specifically with the ERP. Why is better? What are the advantages?
Yes, the therapy, the name of the therapy is CBT, cognitive behavioral therapy, but we use the behavioral therapy with ERP. Why with ERP and don't we use, for example, CBT or cognitive therapy? Because the first reason, the mainly reason is ERP is the gold standard treatment to OCD, to obsessive compulsive disorder. It's the only therapy that when the sufferer can control, can like stop the increase the symptoms. And that is very, very important because with CBT, with cognitive therapy, it doesn't work. It doesn't use and it's not possible. And with ERP, yes, because not only because the control of the symptoms, even the reduce and the habituation, the process of habituation, it works with exposure response prevention, not with cognitive therapy. I used in the past around 10 or 12, 15 years ago in my beginning, the start of my practice office with both, with relaxation, muscular progressive, with cognitive therapy. And what happened with the affect, with the client, with the sufferer? The thing is, after 3 or 4 or 5 sessions, they increase the obsession, they increase the rituals, the compulsion. They getting not better, but it worse. The symptom worse. And I see in many clients that the symptom increase. So when I start my specialization and my BTTI in Houston many years ago, I learned how to use ERP and how to individualize and personalize the treatment with ERP. And I in many years and in many cases, I prove the difference between ERP and cognitive therapy in many and hundred cases.
No, and also data overwhelmingly agrees with you. Scientific papers that shows the two types of treatment, the cognitive treatment versus the cognitive behavioral treatment, specifically ERP, does work. It is statistically significant. There's always the 3 out of 50 cases that don't work, and I found fascinating that you said that even in your practice you have seen not only people getting better with the cognitive behavioral treatment as opposed to the cognitive therapy, but in fact, with cognitive therapy, some of them get worse. Their symptomatology increase. So they actually come back with way worse obsessions. As there being in a particular case where you use both treatments with a patient and with another patient, vice versa. Like, for example, with a patient, you start cognitive therapy, and then you use cognitive behavioral therapy. And then with patient number 2, you switch them, you try cognitive behavioral therapy, and then you try cognitive therapy to see if they actually got better. Has that particular scenario has happened?
Yes, in some not many cases, in 3 or 4 cases, it depends on the symptoms. Is the symptoms are not very aggressive and not very high in the white box scale, and it's a OCD like light, like moderate, not severe. Maybe in 3 or 4 cases can reduce these symptoms, but it's not the like the middle. There is not the average of all the clients. The thing is, and the truth is that with ERP, hundreds of patients can benefit with this kind of therapy with ERP. And so it's a very big difference between the results between ERP and cognitive therapy. And that is the truth in this time.
To engage on a debate and to play devil's advocate, you say that the ERP works because it's the gold standard treatment. We have seen some sort of a medical revolution, especially building up over the last years, but in 2020 the most, the pandemic has signified, which is almost every field is moving to a personalized medicine, individualized treatment. And when I say every field, I'm saying dermatology to personalized brain surgery, to personalized treatment even with the vaccines. Like the people are moving away from everything that is general because it tends to not work. Now we're seeing that we have a lot of genetic differences. We're very heterogeneous population. We have the chemicals in our brain, the hormones, the electrical activity, the way we function. There's a lot of variability from patient to patient, even if they're twins, even when they have the same genetic predisposition or genetic component, there are structural differences because their environment may have been different. The way they cope is different. So people are running away from everything that is universal, standard, conventional, traditional. They want, newer, individualized, tailored, patient-driven, data-driven, personalized treatments. Why ERP should be considered as a personalized treatment, or is it a personalized treatment?
Good question. Good question. And that is the difference between one kind of model therapeutic and another one. Why? For example, the antibiotics, the penicillin, the cephalosporins that they use in some infections. Yes, but depends on the infection, the doctor is gonna administrate or get into a treatment with what kind of, or another kind or another one. What happened with OCD and ERP? Some different subtypes of obsessions and compulsions. Okay, but depends of the what? Depends of the evolution, depends of the several symptoms, depends on the age in the client, depends on the environment, depends on the kind of subtypes, obsessions, compulsions, levels of anxiety. It's useful, for example, exposure in imaginal or in life or interceptive, depends on the case, depends on the client. So ERP works for everyone, yes, but we have to individualize the treatment because it's not the same client. For example, OCD suffered with contamination OCD or with pedophile OCD. It's OCD, yes, but the symptoms are very different. And that is the themes, and that is very, very important because we cannot get into a proper treatment by, for example, an email, or for example, a WhatsApp or a phone call. Is very, very difficult.
Absolutely. So you're saying that ERP is not one unique type of treatment that goes from A to Z. This is how you do it, A, B, C, and that's it. Shut up and go home. You're saying that, wait a minute, yes, the world is moving, the medical field is moving towards individualized treatment, but ERP is part of this individualized treatment because it tailors, it modifies to each specific patient. And you made the analogy with antibiotics. You're saying that ERP is sort of like the umbrella, but just like antibiotics for non-viral infections, doctors, they have many types of antibiotics. They have to change the doses, they change the days. So they tailor the antibiotic treatment to, same with psychologists with ERP?
Absolutely, because the difference is, for example, in ERP, exposure with response prevention, the response prevention is very individual between one or another one. Why? Because in one kind of subtypes, the prevention maybe is around or about 15 minutes, in other one 30 minutes or 1 hour, depends on many things. So ERP works, yes, to everybody, yes, but we have, once again and one more time, we have to individualize the treatment and the time to response prevention. And even the trigger, depends on the trigger, we have to individualize that kind of exposure.
Okay, let's engage on the trigger. You're saying this ERP works for everybody, but you just have to tailor. But what about the worst cases of OCD? Because a bigger advantage of cognitive behavioral therapy, ERP, over just cognitive therapy, okay? It's not that it works in more people across the studies, across the spectrum, but it's hard to imagine, because a main key difference is the exposition, the challenge, the scenarios. If you have a fear, so like an elevator or an airplane, exposing slowly into this stressful trigger that is causing you the anxiety, that is causing you the rumination, the constant repetitive disruptive thoughts. But let's talk about two specific examples. How can someone use ERP, or have you used ERP with people that have OCD, pedophilia, or with a woman that might have a pregnant woman that might have the fear of, might have the obsession of thinking, I want to grab a knife and stab my child inside of my womb, just like we spoke on the Spanish video. Is ERP works in these two types of OCDs?
Absolutely, the ERP works in many different kinds of subtypes and many triggers. Not depends of ERP, depends of the variation, the variety of ERP. For example, in a woman pregnant with, for example, women that has the imaginal of getting to or hurt with a knife,
Imagination. Mm-hmm.
Exactly. The exposure, imaginal exposure is very powerful for this kind of trigger and obsession. With a fear to take an airplane, it's almost exactly with exposure and imagination. But what happens if the trigger and the obsession is, for example, what if I'm turned gay? What if I'm not right? What if I'm a pedophile person? The exposure is exposure to thoughts. Is the most kind of exposure.
Got it.
Depends of the trigger, depends of the obsession, depends of the compulsion, depends of very variety in elements of all the equation.
Got it. Because a lot of the feedback, a lot of the pushback that I'm getting is like, okay, you talk about OCD pedophilia. We understand, in our past videos, they're not necessarily pedophiles. They're just scared of becoming pedophiles. Same with the homosexual. Not that there's nothing wrong about being homosexual. It is absolutely wrong being pedophile, but not homosexual. And also with the cheating on their people. You wouldn't, like, the feedback that I'm getting is, okay, we understand the disorder and we understand the treatment. However, he's saying that ERP, you have to expose. So a person that suffers OCD, and this is just a feedback that I'm getting, is like, So what? A person that suffers OCD, pedophilia, has to expose to children? Like they will go to a park where children are playing and what? Talk to a children? Like that's not, that was confusing for some people, and even from a.
Yes, that's a good comment and a good kind of question, because many people can think, what happened with the pedophile? I have to talk, I have to go to a park. Yes, in some case, depends of the trigger and depends of the compulsion, depends of the case, you have to go to a park, but you have to go to a park with a homework to go. First of all, you have to do exposure to thought. After that, you have to do exposure in imagination or imaginal exposure. And after that, you have to go to a park and do exposure in life. But it's a part of the treatment. But it's like a go or learn how to drive a car or how to get into the pool and swimming. It's like a process, okay? The process is by habituation. You are like warming up.
And it's systematic, step by step.
Exactly.
You wouldn't send someone with OCD pedophilia session to a park. No. You have to make sure they're ready and they have completed successfully. Okay.
Step by step progress is like a warming up in a cold water, and then you learn how to swim or how to drive a car or whatever.
Okay, it's just a quick question. What about someone that has OCD, the relation OCD? Are they going to expose to a person that they want to cheat on their wives or on their husband or significant others with?
Yeah, in many clients with ROCD, relationship OCD, the kind of exposure is with the thoughts and also with going to, for example, like a kiss in the person, or not avoidance, not do the avoidance that is a very common kind of compulsions, or stay in the same sofa watching a movie or watching TV, because the fear is the main person, the relationship. What if I don't love her or love him, or what if she's not the right, or I'm not in the right relationship, or what if my wife is not the perfect wife or the perfect woman or the perfect mom to my children. Okay, so exposure in thoughts is very common, very powerful skill to this kind of subtypes in OCD.
Based on those two examples, I think you're making a stronger argument of why ERP is far superior than cognitive treatment, and why is personalized and individualized treatment. Not so much on the rules, but definitely on specific examples, because you can accommodate it to everybody. Last question of this framework, just to close this section and move into the last section. The case of the pregnant woman wanting to, having the fear, the disruptive thought, the disorder of she wouldn't do it, but just the anxiety of, what if I do this? How can this woman expose a pregnant woman, suffering from this particular fear, have exposition to knives or sharp objects, or even the kitchen within their house? How do you
Yes, for example, if the woman has the fear to be pregnant, and has the fear to hurt herself with a knife, first of all, we have to fear in a low hierarchy of the fear, to begin or to start with anxiety in low levels, okay, with exposure to imaginal. And after that, when the women get improved and get better with the help to the skill, then imagination or imaginal exposure, watch or see herself to hurt to the boy or to the children. But also in life is very helpful and very powerful with the therapist helpful. Why? Because through by online is very helpful, because if you are have the obsession to hurt yourself, okay, go into the kitchen and get a knife and put here in the wrist, for example. Okay, I'm going with you with the ERP to do the habituation that we need to your fear, and down that anxiety, and the habituation increase. And there is a part of the treatment, and that is very powerful to your recovery. And there is a point.
No, absolutely. My last question, and it comes not the personalized treatment, but the personalized diagnose. Okay, then there was a recent movie that talked about very popular on Amazon Prime. Talk about the president and Fit. You have a group of psychologists from elite universities, a group of psychiatrists that said that the clinical interview to diagnose is it's not specific enough, because sometimes the patients can be untruthful. In fact, they even said it might be the last reliable source to diagnose a patient. However, they were talking about antisocial personality disorder, malignant narcissistic. It wouldn't be the same case with OCD. But there are studies regarding not necessarily anxiety disorders, but affective disorders, major depressive disorder, bipolar disorder, that the patient, like if I'm the patient, I'm telling you my level of depression, of suicidal thoughts, it's 6, 6 out of 10. But when you give me a survey, when you give me a questionnaire, I actually put 10. So people are, based on the stigma, based on the embarrassment or the fear that they shouldn't be, of having a disorder, they're more truthful on paper than in person. Why there's no like a OCD questionnaire diagnosis treatment that, you can send to possible patients or people that are worried or watching these videos, and they can fill them out, put the specific symptoms, the frequency, the duration, and then a psychologist will get the 5-page report and make a diagnosis for that. Why is the clinical face-to-face intervention, even if it's telehealth, matters?
Yes, good question. It's very difficult to us to specialize in OCD to help you through a white box scale, a Yale Brown obsessive compulsive scale. That is the main sheet or the main scale to help you to all the symptoms, and also with the subtypes. Why? Because I have to see, I have to study different things. For example, the evolution, for example, the kind of OCD, for example, your age. But the most important thing is your symptoms, clinical symptoms. I have to watch to you. I have to see you. I have to see some
gestures and signs. How do they respond when they talk about something?
Yes, your face. I have to see your face and your symptoms, clinical symptoms, and it's very difficult through an email or through a survey or through a sheet. So we don't recommend to, when we receive 100 or 10 or many email through all the world, so can help me through an email. This is OCD, for example. What is the proper treatment? How I can use the ERP? It's very difficult. It's impossible, because I have to
email me a therapy.
It's almost impossible. It's like send an email, surgery, or to, okay, I have a pain here in my stomach. Okay, what is that? There is a hernia, there is a problem with your what? It's it's impossible. So the best way and the most honestly way and truthful is the via online, through Skype or through a video. In this time with the pandemic, the video is very helpful, and that is a very kind of type or therapy to help many or 100 sufferers in all the world. That is the point, and that is the reality.
From the clinician, from the clinical perspective point of view, it's not enough to know the symptoms on an email saying diagnose yes, no, much more less the therapy, absolutely. Although I imagine people asking, prescribe me some sort of a meditation exercise, so I'll do it, okay? But from your point of view, you're saying that there's a lot of body behavior, the tone, the facial expressions, the way the person is describing the symptoms, that someone can say, I feel this disgusting, but then you actually find that based on their tone of voice, based on their body behavior, based on their facial expressions, based on the time they talking about it, you actually find the most proper treatment that is reliable, objective by that clinic, by that one-on-one meeting.
Exactly. Also, the level of your fear or the level of your anxiety. If you are talking to me and you are very fear or you are very quiet, or what are your symptoms? I have to look at you.
Okay, yeah.
What
This
proper?
was no, absolutely not. I think you made a strong argument why ERP is cognitive behavioral treatment is far superior with specific examples than cognitive therapy. Why just because it's gold standard doesn't mean it's not personalized. It can be personalized and individualized. And you made a strong argument of why in this specific case with OCD, stress-related disorder, anxiety-related disorders, the clinical intervention is a must. Is fundamental. It's not enough an email, watching all the videos, reading all the books you can. You need to speak with an expert. You need to speak with something that at the Bar Exchange we strongly emphasize. You need the clinical intervention for that. So Alejandro, International Awareness Week starts today. Tomorrow, 7 p.m. Facebook Live in Seville. And there's a couple of other conferences. We're gonna keep checking your website and also the website on the Bar Exchange, where we're gonna post all that information. Thank you very much. It was a pleasure.
Thank you, Luigi. Thank you for having me, and see you in the next episode. Bye-bye.
Absolutely. Thank you so much. Stay well. Bye.